Welcome, everyone. I'm Deborah DeBruin. I direct the Center for Bioethics here at the University of Minnesota, and I want to welcome you all here today to our Ethics Grand Rounds. We're gathering today to discuss racial inequities in reproductive health. This is a critically important topic, and one that it is especially fitting to elevate as we near the end of Black History Month and move into Women's History Month. As you may know, the American College of Obstetricians and Gynecologists has designated the dates at the end of February and the beginning of March as the Betsey, Lucy, and Anarcha Days of Recognition. You'll find more information about that designation linked in the presentation details document that Center for Bioethics staff will post in the chat. In so doing, ACOG asks us to reflect on the racist history in reproductive health care, including the abusive experimentation involving enslaved Black women during the mid-1800s that led to significant advances in obstetrics and gynecology. While today's talk will not focus mainly on this history, it will aim to describe how ongoing forces of structural racism affect reproductive health outcomes today and to make recommendations on how we can promote equity. Before we begin, let me briefly address some logistics for today's session. We will have a discussion period after Dr. Hardiman gives us her presentation today. If you have questions for her, please use the Q&A function either to pose or to follow up on your questions. You can type your questions into the Q&A at any time during the talk. You do not have to wait until after the presentation is over, although we will be waiting until after Dr. Hardiman's presentation to address your questions. You can also use the Q&A to let Center for Bioethics staff know if you're having technical difficulties. Please do all of your communication using the Q&A function. Don't use the raise your hand function. That is not working for us today. This session is being recorded, and you will be able to access the recording within just a few days at the website that you see there on the screen. We would ask that you complete an evaluation of today's session. There are 3 ways to access that. When you close out the webinar at the end today, a link to the evaluation will pop up in your browser window. And if you have time and desire to fill it out right away, please do. Otherwise, there is a link to the evaluation form in that presentation details document. And you will also receive an email after the event with a link to complete it if that's more convenient for you. But we do really appreciate it. Next slide, please. There are 3 ways to get credit for attendance at today's webinar. If you are a U of M student with active status in one of our health professions programs, you can pursue interprofessional education credit for attendance at today's webinar. We ask that you complete the reflection form linked in that presentation details document in order to earn that credit. You can also request a certificate of attendance for CEUs for attendance at today's webinar. Please complete the form in that presentation details document, which I'm sure you're beginning to understand is a great resource for you today. That document, again, is available in the chat. It can take a few days for those certificates to be issued. And I should note that you will need to attend at least 75% of today's talk in order for us to be able to issue that certificate, given the requirements of the accrediting agencies. Biomedical engineering students, you can indicate your attendance at today's webinar by emailing your program. The email address is there on the slide, and for your convenience, it is also included in the presentation details document. Next slide, please. I would like to thank our co-sponsors. Those of you who are regular attendees of our Ethics Grand Round series know that we rely heavily on our partners to help plan these events. So our co-sponsors for today are the Program in Health Disparities Research, the Center for Anti-Racism Research and for Health Equity, the School of Public Health, the Center on Women, Gender, and Public Policy, the Gender, Women, and Sexuality Studies program here at the U, the Center for Race, Indigeneity, Disability, Gender, and Sexuality Studies, the Center for Women's Health Research, the School of Nursing, and the Medical School. We are very grateful to our partners for helping us bring you this webinar today. Without further ado, I'd like to introduce our speaker. As usual, I'll give a very brief introduction so we have plenty of time to hear from her. It's really my honor to introduce Dr. Rachel Hardiman, who is a tenured associate professor in the Division of Health Policy and Management at the University of Minnesota School of Public Health, the Blue Cross Endowed Professor in Health and Racial Equity, and the founding director of the University of Minnesota's Center for Anti-Racism Research for Health Equity, which is also a co-sponsor for today's talk. She has a very distinguished record of research that is geared toward demonstrating the ways in which racism affects health and charting a path toward health equity. She's been the recipient of numerous awards for her research. You can read more about her work in the presentation details document that's linked in the chat. At this point, Dr. Hardiman, I'll turn things over to you, and thank you so much for being here with us today.
Thank you so much for having me. I'm just going to get my slides up and running. There we go.
That's perfect.
Great. Thank you for confirming. So good afternoon. I'm really honored to share this virtual space with you all today. I admire the work of the Center for Bioethics and share your mission to drive for an ethical, equitable future in Minnesota and beyond. Today, I'm going to share with you some of my thoughts and some of my work in the fight for reproductive justice and reproductive health equity. Sorry, my slides are not advanced. There we go. But I want to take a moment first just to honor Betsey, Lucy, and Anarcha, and all of the other unnamed enslaved Black women who were subjected to abusive experimentation in order to advance the practice of obstetrics and gynecology. While I'm not a historian, I do discuss the history, this history and much more as I talk about my research, because I think it's incredibly important to understand the past in order to figure out our next steps and where we should be headed. And so I feel greatly honored to be able to stand in this space today and share that with you. So I want to start by centering us on what I see as core to my work and to our collective work, and that's the notion of love. And what you see on the screen are words that I shared with our community a couple of years ago in collaboration with Penumbra Theater when we hosted an event called We Are Love. And what I said was, Black people are loved. We're made out of love. We show over and over again that love is the most powerful force on this planet. We are the embodiment of the power of love to persevere and to flourish. We have used love to heal and to find strength when we thought there was none. It is the love from and of our ancestors that will continue to nurture us in our time of need. And this love of ourselves and our community will hold us as we stand strong in the face of today's challenges and tomorrow's triumphs. So I often come back to these words in my work in the day-to-day because I find them to ground me, especially when things feel incredibly hard. So I want you to just imagine for a minute what love looks like for you. It could be the love you have for your children, your partner, a friend, a community of people, a parent, a passion or a hobby, whatever that is for you. And then I want you to hold that in your consciousness. And so I'll give you a second to kind of get to that. So here's what typically comes up for me. The world I imagine is one filled with unquestionable and unconditional love for my daughter, Layla, and my nephew, Leo, and other Black and brown babies and children, where their lives and their humanity are valued and they are loved. And that's what leads me to the goal of my research, which is to manifest racial justice so that Black women and girls can live their full greatness and glory. So I come to you as a mother, as a daughter, as a sister, and as a Black scholar who works day in and day out to manifest change so that Black women and girls, so that Black birthing people in our country receive liberation. As a professor and as a researcher, I use the tools of science and inquiry to create an evidence base to enact change. And in order to do that, I feel very strongly that we have to be able to explicitly state that we love Black and brown people, that we're willing to protect them, that we are prioritizing our safety, and that we believe in our humanity. And I say that explicitly because I think we have a lot of examples right now, as well as historically, that run counter to these values. That's why we're here today. And I think it's important to understand and very clearly articulate what we're up against because it makes the path forward just that much more clear. So today I'll share with you some data and some stories as we begin to sort of imagine and reimagine what's possible on this path towards reproductive health equity and liberation. And to start that, we have to be able to define and talk about structural racism. Structural racism is at the core of the research that I do and the core of the discussions that I have as I think about achieving reproductive health equity. And you'll hear and understand more about why that's the case in just a minute. So there's two definitions of structural racism that I often rely on in my work. The first you see on this slide is from Dr. Zinzi Bailey, in which she states that structural racism is the totality of ways in which societies foster racial discrimination through mutually reinforcing inequitable systems like housing, education, employment, earnings, benefits, credit, media, criminal justice system, the policing system, etc. And those in turn reinforce discriminatory beliefs and values and impact the distribution of resources, which together affect the risk of adverse health outcomes. I also rely on the definition you see here from Dr. Kamara Jones, who is the former president of the American Public Health Association and one of the world's most preeminent scholars in the study of racism and health. And she describes it as a system structuring opportunity and assigning value based on the social interpretation of how one looks, which is what we call race in our society. She also points out that structural racism unfairly disadvantages some individuals and communities, unfairly advantages other individuals and communities, and saps the strength of the whole society through the waste of human resources. And I think it's really particularly important to highlight that last point, that because of structural racism, we are sapping the strength of the entire society through the waste of human resources in so many ways. And I think this resonates deeply as we think about maternal health and maternal health outcomes and the chances that are lost for birthing people to become mothers and for infants to be able to have a healthy and safe start to life. So additionally, when I talk about structural racism, I make sure to note that, or make this the distinction between implicit racial bias and structural racism, because implicit bias all too often becomes sort of the default for us. I think it's become comfortable language where we, feel okay sort of having those discussions around unconscious bias, which is great because there was a point where we couldn't do that. But as we push the needle and really continue to do the work of dismantling structural racism and working towards health equity, we have to understand that while implicit bias is important, it's a process of associating stereotypes or attitudes towards categories of people without conscious awareness. And that, it's insufficient, I would argue, for advancing the sort of greater goals of equity. Rather, we have to understand how implicit bias is sort of situated as part of this larger conversation around the systems and structures and institutions that are creating and perpetuating health inequities through structural racism. So one of the things I've learned over the past few years in working within and alongside community is that those same definitions of structural racism that I just shared with you from Dr. Bailey and from Dr. Jones, and even the distinction I just made between structural racism and implicit bias, they don't necessarily resonate with folks in community or those of us who are doing this work or thinking about leading and enacting change outside of academia, outside of the academy. So, you'll hear me come back to this theme of, building collective power and using that to dismantle structural racism and to achieve reproductive health equity. And in order to do that, I think we have to be really thoughtful about the language we're using and the power of those narratives, both to disrupt harmful narratives, but also to create new and accurate and evidence-based narratives. And that's a lot of the work. You'll hear me talk about the Center for Anti-Racism Research for Health Equity in a bit, but a lot of the work that we do sits in that space of how do we leverage the research that we are generating to change the narrative. This is also why I think it's important to frame this work and think about, this topic today within the reproductive justice movement. So the notion of the reproductive justice movement, or of RJ, was developed in 1994 by a group of Black women who recognized that the women's rights movement, which was led at the time by middle class and wealthy white women, was never going to be able to defend the needs of women of color and other women who were marginalized or identified as trans or other, right, in some way. And so what they realized is that they needed to lead their own national movement to uplift the needs of the folks that were not, were in the margins, were not at the center. Another sort of idea that you'll hear me come back to a little bit later. So the comprehensive perspective of the reproductive justice movement really embodies women of color's recognition that it's not only important to fight for the right to have a child, or not have a child, but that it's equally important to advocate for the right to parent the children that we have in safe and sustainable communities. So that means communities that are free from crime, free from police violence, free from surveillance and state-sanctioned violence, and filled with love. And right now, I would argue that structural racism robs us of our ability to live and raise our children safely and with humanity and with love. So as we think about and conceptualize and operationalize structural racism, both for purposes of research, but also in our day-to-day work, for those of us who are clinicians and providing care to large, communities and populations, we have to consider and measure and understand how structural racism is showing up and how it's impacting the lives of the people that we care so deeply about. Just a quick note before I sort of jump in to the next section on terms. Just as I said, changing the narrative matters, words and language matter as a part of that. You'll hear me use the term birthing people because we strive to, ensure that we are using accurate and inclusive language and recognize that gender identity is separate from biological sex. So we use the gender inclusive term birthing people, and you'll hear me use that term and sometimes go back and forth between women or mothers, depending on sort of what the data and sort of what the what's being depicted on a particular slide. But happy to talk further about that in the Q&A. So I know you heard that I was not going to touch on history. I have to share some history because I think, again, it's incredibly important for the context of understanding how we got here, right? Why we are in the situation that we're currently in. And so I'm going to start by just pointing out a few data points and putting them in within the historical context so we have an understanding of where we've been and where we're headed. So as long as we've been collecting data on infant mortality, we've seen that there's an inequity between Black and white infants, such that Black infants are more likely to die in that first year of life. And so while the infant mortality rate overall has improved over time, that racial gap between Black and white infants has persisted for centuries. Actually, historical demographers estimate that in 1850, enslaved infants died before 1 year of age at a rate that was 1.6 times higher than that of white infants. And for reference, more recent data shows that Black infant mortality is now 2.3 times higher than infant mortality for white infants. And the racial inequity in infant mortality is certainly steeped in a history of chattel slavery in the United States. And what you see on this slide is the cover of a book written by Harriet Jacobs called Life of a Slave Girl. And in that book, one of the things that Harriet Jacobs did was recall the dilemma she faced as a 16-year-old enslaved woman when her infant son, Joseph, was born into slavery and became ill. And she stated, alas, what mockery it is for a slave mother to try to pray back her dying child to life. So her reaction, right, to her son's birth, highlights this sort of seeming inevitability of infant death, right? This expectation that most infants aren't going to survive. And she also was reflecting on the fact that perhaps that was a better existence than the one that awaited her son as an enslaved Black male during that time. So throughout our history, childbirth was not just dangerous for the infant, but also for the mom as well. Maternal mortality, the death of a pregnant person during pregnancy, childbirth, and the year following was sadly the norm during slavery for both white and Black birthing people. As historian Judith Leavitt has described, the quote, haunting shadow of maternity touched on many aspects of women's lives as women endured frequent cycles of pregnancy and childbirth, well aware that maternity, the creation of new life, carried with it the ever-present possibility of death. However, for Black enslaved women, the commodification of their bodies in the name of capitalism and of medical innovation and science left them vulnerable and harmed even more frequently. And we can't disconnect that, right, from the reality we currently face in the United States, which tells us that while, as a nation, we are the only industrialized nation with a rising maternal mortality rate. But even more concerning is the fact that Black birthing people are 4 times more likely to die of a pregnancy-related cause than their white counterparts, and that's regardless of education and socioeconomic status. So, the bottom line here is that we have to be thinking about how the legacies of slavery are seen in structural racism that's resulted in disproportionate maternal and infant death among Black birthing people and Indigenous birthing people in our country. I think for the sake of time, I won't dwell into this slide other than to mention that while our focus is often on maternal mortality, we have to be paying attention to severe maternal morbidity as well. And there's a lot of really important work by Dr. Elizabeth Hull and others going on in that space. I also, because we're here in Minnesota, want to highlight the recent Minnesota maternal mortality report, where we find that while Black birthing people in America make up 13% and American Indian birthing people 2% of the portion of the birthing population in Minnesota, both groups are disproportionately represented among the pregnancy-associated deaths, making up 23% and 8% of those deaths, respectively. So again, we have a lot of work to do. And I've already sort of started to plant that seed that at the root of these problems is structural racism. And I think it's important to understand just really briefly sort of how that works, right? Because it shows up and it works in a lot of different ways. We don't have time to dig into all of them, but I will highlight, because I think it's important, some of the ways that this is happening. So first, we have to think about the social determinants of health. So the fact that where we work, live, and play matter for our health and well-being, meaning that the environmental conditions, neighborhoods, access to education, all of those things are disproportionately impacting Black and Brown communities in ways that are harming health and well-being. We also have to think about the weathering process. So this idea that the physiological consequences of the constant stress due to all forms of racism is contributing to inequities in maternal and infant health. So constant exposure to structural racism, creates this sort of fight or flight response in the body, and therefore bodies may be releasing higher levels of hormones, of cortisol, neurotransmitters that are contributing to diseases like hypertension, heart disease, diabetes, and other chronic conditions that are leaving Black birthing people in particular sort of less healthier at suboptimal health going into pregnancy and childbirth. Additionally, I think it's important to state clearly that evidence has indicated that the weathering effect is associated with an 8-year shorter lifespan for Black women than white women. And then we also have to recognize that structural racism isn't just happening outside in the sort of social environment where we live, work, and play, but it's also happening within our healthcare delivery systems. So our healthcare systems are microcosms for how white supremacy and racism are playing out in our broader society. And that's because there's this long history of healthcare systems dehumanizing Black bodies in a variety of different ways that we'll dig into in just a moment. And as a result, Black birthing people are engaging with a system that was never actually equipped to ensure that they thrive. So I'm going to, again, I think for the purposes of time, I may skip a few slides here and there, but again, I think that this history and understanding medicine's relationship to chattel slavery in the United States is incredibly important as we understand the role that our healthcare delivery systems in particular play in both fixing the problem and also contributing to the problem. So just to be clear, and from its earliest origins of chattel slavery in North America, what we saw were European doctors or those with medical training serving the interests of slave owners rather than the enslaved patients themselves. So sometimes that looked like transatlantic slave traders hiring surgeons for the Middle Passage in hopes of preserving their human, cargo for maximum profit. These distorted priorities were reflected in medical journals. You can actually look at medical journals from 1858 and beyond, where it was declared that the ability to accurately determine the market value of Black bodies was one of the key professional medical competencies for Southern doctors. We also see it show up in insurance companies and who were hiring white physicians to examine enslaved people before issuing life insurance policies to protect slaveholders' financial well-being. A lot of this history is outlined in a beautiful piece published in 2019 by Dr. Deirdre Cooper Owens in the American Journal of Public Health. And I think I will skip the next two slides because I think they reiterate a lot of the points I just made and help us to understand that again, these notions, these ideas are deeply embedded in our healthcare system and all of our systems. But as we think about this from a bioethics point of view and from a healthcare delivery and public health point of view, it's been deeply embedded in those systems from the very beginning. And I always like to show these timelines because I think they're important for understanding exactly how deeply ingrained this history is and all of the ways that racism and white supremacy have taken different shapes and forms over time to maintain the status quo, right? So it's a very dynamic process that's showing up in different ways depending on what we're dealing with at a given time. And we've certainly seen that over the past few years. And one of the other important takeaways from this slide is that Black enslavement comprises 60% of our country's history. And Jim Crow, so those state and local laws that enforce racial segregation, make up 20% of our history. And so this history has fundamentally shaped who we are today through a series of racist policies fueled by racist ideas and ideologies. It's framed every institution that we access. And so we have to think about that and we have to be acutely aware of that as we do the work of changing it. In 800 pages in Sam from the beginning about how this all sort of has played out, right? And suggests that racist ideas, we've started with these racist ideas and then discriminatory actions that were wrought by self-interest, during slavery come first, then racist ideas are developed to justify that self-interest. And then those ideas spread and they become norms and they become the narrative. So in other words, racist beliefs were created to prop up the institution of slavery and justify the poor treatment of Black people. And then that rationale spread and multiplied. So things like Black people or enslaved people are hardy or made for work, can't feel pain, had thicker skin. Those are all constructed to justify slavery, and they show up still today. Those ideas, those notions underlie a great deal of the beliefs that we see show up right now in our healthcare delivery system. Because we are honoring Betsey, Lucy, and Anarcha, I think it's important to use this example of when a racist idea becomes a racist action. So James Marion Sims, who was once known as the father of modern gynecology, took racist ideas and translated them into racist actions, conducting research on enslaved Black women without anesthesia, which had recently been introduced. And one of the racist ideas at the foundation of that practice was that in addition to their status as enslaved people, that Black women were considered appropriate subjects for experimentation based on the widespread belief at the time that Black people experienced less pain. And this idea is often referred to as "quote unquote" obstetrical hardiness. That this notion of obstetrical hardiness sort of became an influential racial folklore within medical theory and practice because it harmonized so well with the racial ideology that had already shaped Western thinking about racial differences and allowed for the justification of Black bodies to be used for research. So we have to ask ourselves, how does this show up now? What does that look like? And it may not sort of be as explicit as we would want it to be, but it is there in many shapes and forms. And there's a lot of scholars who have done some incredible work to sort of begin to uncover these things. So a couple of examples that I like to share are from colleagues across the country. Saraswati Vedam and her team at the Birthplace Lab conducted the Giving Voices to Mothers survey and found that 1 in 6 birthing people report experiencing one or more types of mistreatment, such as loss of autonomy, being shouted at, being scolded, disrespected, threatened, ignored when requesting or needing help during prenatal visits, during pregnancy, and during childbirth. One of the leading Black scholars doing work in maternal and child health, Dr. Monica McLemore, has done some incredible qualitative work reporting that for birthing people of color are more likely to experience disrespect during healthcare encounters, including experiences of racism and discrimination, reporting stressful interactions with staff and unmet information needs. My work with Dr. Laura Atanasio is a fantastic scholar at UMass. We found that, birthing people who reported having declined care for themselves or for their infant during the childbirth hospitalization period were more likely to report poor treatment based on their race. We also found that the increase in odds of perceived discrimination was due to a difference of opinion with the healthcare provider was significantly larger in magnitude for Black birthing people in comparison to their white counterparts. Additionally, there's been, these are just three examples of how this disrespect, mistreatment, and these underlying notions, are bubbling up in the ways that Black birthing people are reporting being treated during pregnancy and childbirth. I also think it's important to understand what's happening, not just for the mother, but for the infant. And in this study, my colleagues and I were really interested in exploring this idea of racial concordance, meaning the idea of a doctor or physician sharing the same race with their patient. Racial concordance in previous work has been found to improve patient satisfaction. It's been found to increase the likelihood of a patient choosing to return to a given doctor's office or be seen again. And communication is often cited as a primary reason. Patients say, are more satisfied with the care because they found a physician who may share their lived experience, may making it easier for them to communicate with them and sort of share their lives with them and get the help that they need. However, there's been very little research that's actually looked at or been able to assess if racial concordance has an impact on actual health outcomes beyond, so not just sort of satisfaction and likelihood of returning to a clinic, but does it actually impact the health outcome? So we pose the question, does patient-physician racial concordance ameliorate the disparities experienced by Black newborns? I already shared with you sort of the data and what we're facing and what we've been facing for centuries when it comes to the reality of Black infants in our country. And what we found very briefly after looking at 1.8 million births over 15 years in the state of Florida was that Black newborns during that newborn hospitalization phase are less likely to die if they are being cared for by a Black physician. And I want you all to sit with that for a moment and consider the fact that, in these interactions, that communication element doesn't exist, right? Because newborns don't have the ability to communicate well with words. So I think these findings really ask us to think carefully and critically about what's happening. And while we in these analyses cannot study sort of the mechanism behind that, I think that as we consider the history that I just shared with you, and the data that folks across the country are collecting to understand these experiences for Black birthing people, we have to be able to understand and grapple with and sit with the fact that a lot of this has not been addressed, right? And it's not about, often when after the study was published, we often got questions around, or well, maybe not even questions, actually accusations is probably a better word, suggesting that or accusing us of suggesting that that individual physicians or clinicians were harming Black infants, which that's not what our research, our findings say at all, but also I think is highly unlikely. I would argue it's very unlikely, but what it does tell us is that there's something happening within the healthcare systems and healthcare delivery institutions that has to be addressed to be able to ensure that everyone has that chance to thrive at the start of life. So I want to briefly share this conceptual model that I, along with some amazing colleagues, created to describe the processes of how racism operates to create racial inequities in maternal morbidity and mortality. I know it's probably a little bit hard to see on your screens right now, but I share it because I think we do our best here to kind of comprehensively describe both the historical context of racism in the United States and how it's precipitated the contemporary forms of racism that can be described as interpersonal, internalized, institutional, and structural. And also indicates or illustrates that these things don't happen in isolation. They're all interconnected and they feed off of one another. And they show up in a lot of different ways. We could, we would need pages and pages and probably still couldn't capture all of the ways that it manifests both in our society, but also in healthcare, as you see in sort of the furthest boxes. But I think as we're thinking about solutions, as we're thinking about what can we do, we have to understand that sometimes, in healthcare, it might show up as failed shared decision making, delays in treatment, low expectations of patient engagement, victim blaming is often something we hear a lot about within the maternal child health space as problematic and a symptom of experiencing racism. So happy to come back to this if there's time, but don't want to spend too much time with it right now, because I want to shift into talking about what it means to cultivate our collective power. I've outlined a lot of problems. I've outlined or shared some of the history that's contributed to it. But ultimately, the goal is to do something, right? Is to do something to change things. And I'm the first to say that I and we don't have all the answers, right? And I think for some people, that's incredibly unsatisfactory. I often get asked for a checklist or a playbook. People want to know just how can I just simply be anti-racist? And it's not that simple, right? I mean, and I think everything I've shared with you today indicates that it's not that simple. We're talking about over 400 years of ideas and ideology that's been manufactured and narratives that have been created and embedded, and we haven't even uncovered all of the ways that it shows up. But that doesn't mean we can't start doing the work and cultivating collective power for change. And I would argue that starts with ourselves. It starts with us each understanding what our role is and what our responsibility is, and to dismantle structural racism and to support Black lives. This paper I published with my dear colleagues, Dr. Katie Kazimano and Dr. Eduardo Medina in 2016, just after Philando Castile was killed by a police officer here in the Twin Cities. And we wrote this as a call to action to our colleagues, to people who we were, working side by side with, who we wanted to understand that there are steps that we can each take, even when these even when these issues feel insurmountable and feel so big, we each, again, have a role to play. So we started by talking about the fact that we have to learn about, understand, and accept the United States racist roots. That's the history part that I offered to you today. We have to understand how racism has shaped our narrative about disparities. The example I used today was obstetrical hardiness. We have to be able to define and name racism in all of its forms, right? So I focus quite a bit on structural racism because I think that getting at sort of the way that structures are built and contribute to and manifest structure our racism is incredibly important, but that has to be understood in concert with implicit racial bias, institutional racism, and other forms. We have to recognize racism, not just race, as the fundamental cause of inequities. And we close that piece by talking about the need to center at the margins. Again, a notion or an idea I had shared earlier, and and I think what I mean when I refer to centering at the margins is that we understand that for any defined group, especially one with power and influence or control, that there's a center, right? And then there's the margin, where the center has more power, more influence, more control than the margin. So the RJ movement is a perfect example of that. It was born out of the need to center at the margins and ensure that the people on those margins had power and were centered in the work of reproductive rights and reproductive justice. I'm short on time. There's so much more I could say about centering at the margins, but I'm gonna keep moving because I do have a few more slides I want to share before we move into question and answer. So we have anti-racist self. We also have to think about anti-racist practice in the patient encounter. I'm not going to spend a lot of time on this slide either. I'll just encourage you all to go read this piece that I published with Dr. Jayma Karbia, as an assistant professor and here at the University of Minnesota, and Dr. Katie Pazimano, where we argue that to improve clinician-patient interactions for Black birthing people and others who are at greatest risk for adverse maternal and infant outcomes, we have to use an anti-racist framework that undergirds this idea of relationship-centered care. And so what we know is that relationship-centered care sort of contends that all illness and healing processes occur in relationship, and that's relationship with an individual or of an individual with self and with others, and that depending on those interpersonal relationships, specific or especially the one between a clinician and a patient, by really using a sort of critical race or an anti-racist lens, we can shift what that looks like. And again, happy to talk about that more in the Q&A as well. And related to that clinical encounter, we also have to be thinking about anti-racist healthcare systems. And this piece that was published in 2020 now, just after George Floyd's murder, we talk about what we should be doing as anti-racist healthcare systems to improve, to build that collective power to impact health equity. And we start by talking about simply the need to divest from racial health inequities. So we have to understand that racial health inequities are not signs of a system malfunction, but rather they're a byproduct of a healthcare system functioning as intended, right? And I think a lot of the research and a lot of the evidence I've shared with you today supports that. And then the question is, what are we going to do to change it? One of the things we pose in this study or in this paper is that we have to desegregate the healthcare workforce. So what we see here is not only is the birth workforce lacking in diversity in terms of training and discipline, but it doesn't reflect racial and ethnic identities of birthing people in the United States. For example, while 14% of birthing individuals in the US identify as Black, only 6.3% of certified nurse midwives and 11% of OBGYNs identify as Black. And, this doesn't even touch on sort of the challenges around training for doulas, midwives, and other healthcare providers in the birthing space. And then we talk about the need to make mastering the health effects of structural racism a professional medical competency. Medical schools have a responsibility, right, to equip every single clinician, every single future physician with the knowledge to address racism. in their patients' lives. And we should have licensing and accreditation and qualifying procedures that test this knowledge, just as we test other essential professional competencies to become a physician. The same goes for our healthcare systems meeting rigorous safety and quality performance standards for accreditation. We all know sort of what that process looks like, and we could certainly add in a process that requires that our systems are meeting rigorous standards for addressing structural racism and achieving equity and outcomes within their hospital system. And I know I am short on time, so I am going to move through the last couple of slides very quickly. I apologize for that. So we've covered anti-racist self, and anti-racist clinical practice and anti-racist healthcare system. We also have to ask ourselves about, how do we contribute to anti-racist policy? I won't go through the details on this slide, but again, in this paper that was published just as the Biden-Harris administration was coming into office, offers some ideas for how we can be thinking about addressing structural racism and dismantling structural racism through federal policy, whether that's a White House Office of Racial Equity, supporting universal comprehensive single-payer healthcare, and reparations, to name a few. We also have to be focused on policy at the state level when it comes to reproductive health. And here you'll see a couple of examples of what's happening both in Minnesota and other states. I'm happy to dig more into that as well. And I close with anti-racist research. I know not all of us on this webinar today are researchers, but as a researcher myself and someone who's been trained to develop an evidence base that understands these sort of big and tough challenges and issues in our society, I think it's incredibly important that our research is built around the principles of anti-racism. This piece that I published a couple of years ago with Dr. Carbia really digs into this. And I'll just offer one example before sort of closing out my talk today. And that's that we have to understand again that the predominant notions about race shape the way that we as researchers are framing our research questions. So one example we use in the paper is that research questions are often phrased as, what causes Black people to have so many disadvantages compared to white folks, and what forces are at work. And we have to understand that, that question, and I am also guilty of posing similar questions, right? Because that's how we've been trained. These questions or variations of them are, widely used again, and at sort of face value look pretty innocuous. However, in reality, this type of question can reinforce racism and reinforce white supremacy, suggesting a Black deficit, and subtly reinforcing, going back to that narrative piece that I started with, we end up subtly sort of reinforcing a narrative and a story that's privileged over other stories. We also talk about in this piece sort of how that leads, those research questions can then lead to flawed methodology, which is going to lead to flawed sort of interpretation of findings, and ultimately a conflation of race with racism, rather than an understanding of racism and the structures that have contributed to reproductive health inequities. So in order to do anti-racist research, I believe we have to embrace our radical imagination. I believe that innovation within the status quo is not enough, right, to save Black moms. It's not enough to save Black babies. It's not enough to manifest racial justice. The radical imagination often emerges most brilliantly from those who encounter the greatest or most acute oppression and exploitation, meaning we have to center at the margins. And it's also, I would say, not just enough to dream about different futures. It's about drawing on that past, that historical context, and then telling a different story about how the world became the way it is, and then remembering the importance and the power of those previous struggles and using that on our path towards liberation and to build something bigger and something bolder. And that's one of the reasons for anti-racism research for health equity. 2 years ago today, today is our second anniversary of the founding of CARE. And, what you see on this picture is a vision board created for us by community members in North Minneapolis. We gave them the prompt, what is your vision of racial justice for our future? And they dreamed big and they dreamed beautiful. And we continue to dream alongside our community partners. What we know is that the work of anti-racism is fueled by love and love for Black, Indigenous, and racialized communities is what's driven us the past 2 years and will keep us building on our momentum. And it's been a wild ride. I can't even tell you how wild of a ride it's been for the past 2 years. You know, and the goals that you see, the goals that we have for the center are guided by every aspect of our work and of our founding. And I would be remiss if I don't close by saying that, you know, I believe that collective power requires that we have a team of people who are willing to do the hard work, are willing to dream, and who reflect the mission and the vision and the values and the goals, and want to support and build that radical imagination. So I want to close today by honoring those folks, the people you see on this slide, these beautiful faces who have been along for a wild ride the past 2 years, as we build and reimagine and build a new reality for Black birthing people and their families, and for all people. And so with that, I will close. I look forward to your questions. I will just close by saying that I believe that the path to liberation and to health equity means that we have to be willing, again, to lead with love, and we have to come together as communities with love and purpose so that we can change the world. Thank you.
Thank you. Very much appreciate that, and congratulations on your anniversary.
Thank you.
So before we move into the Q&A, I just want to note what I should have noted at the outset, which is that the theme this year for the University of Minnesota's International Women's Day event series is Embracing Equity and Justice in Reproductive Rights. So if you are interested in today's talk, you may be interested in learning more about the other talks as well. I believe that Kayleen has added information about that series to the presentation details document, and we'll be adding a link to other events in that series into the chat for today. So now let's move into the questions for you, Dr. Hardiman. I do want to call out, and I don't want to take a lot of time to talk about this here, but there is an attendee who asked how folks can financially support your center. So if you would like to be in touch about that.
Yes, that is a very kind question. There's information on that on our website, and also all of our social media today has instructions on that as well. But feel free to reach out to anyone on our team. If you Google care or put in care.umn.edu, all of the information will be there. Also, thank you. Our manager of communications, Kelia, just dropped a link in the chat. So there we go. Wonder, did we lose?
I think we've lost Deb.
Oh, yeah. Well,
I am helping to scroll through some of these wonderful questions.
Thank you.
I think, you know, everybody is really wanting to connect with this idea of dreaming and finding your team. And there's a lot of support here about what to do next. Could you, and lots of gratitude as well. Maybe could you talk about, I'm looking at our time and trying to summarize a question for you, which is challenging. But maybe you could address what advice you could share about how to engage effectively with people who are resisting the truth around structural racism.
Yeah. Oh, that's a great question. I get that question a lot. And what I have come to learn over many years now is that you can't engage effectively with folks who are just completely resistant to the truth and to the reality of our country and our country's history, right? So I look at it as sort of a range or a spectrum of folks, right? And my goal often is to target people who are not so far on one end that they can't hear the message, but really the folks who are kind of creeping towards the center a little bit more, because I think there's a chance there, right? And this work, I think we have to realistically think about the fact that we have to be in this work for the long haul, right? It's a marathon, not a sprint. And we will very quickly wear ourselves out in ways that, you heard me talk about weathering, like that's very real. And we will very quickly wear ourselves out if we are trying to speak to an audience that is not, and that is unwilling to hear, right? But I think there's folks who are less unwilling, right, but are still not completely there yet. And those are the folks that I hope to try to bring along. I think that there's a lot of power in research and in evidence and in data, as well as, we couple that with stories, right? Because behind every data point, behind every number in our research is a story, is a life, is someone who was loved. And so being able to highlight both of those to and disseminate those that, in a way that can impact either impact policy, but also start conversations, and then recognizing that then those conversations have to continue, right? It's not a one and done. And so that's, I feel like that's the unsatisfactory answer to that question.
Thank you, Dr. Hardiman. I'm really hearing what you're saying around listening to one another's stories and how important that is. And maybe we could end on your response to how people could get involved. We have a couple of questions specifically around maternal fetal medicine physician and bioethics graduate student wanting to be more involved in this space and conversation. And another person asking if the center has any upcoming projects open to collaborators.
So I am going to refer to our website, which I'm hoping Kelia will drop in the in the chat as well, for involvement. Going to our website, you can then join our listserv. We send out beautiful newsletters. We just sent out one this morning. We also are in the process of launching probably 3 or 4 studies where we'll be recruiting particularly people who identify as Black and are pregnant or have been pregnant in the past few years. And so you'll find that information as well on our website. We also are, now that we're coming back to in-person gatherings a little bit more. We recently hosted a community conversation for folks doing work in the birth equity space, and we'll continue to do things like that where folks can come in and get involved, hear what we're working on, offer us feedback, offer us insight sort of as we move the work forward. So I look forward to engaging with you all.
We are so honored to have you here with us today for our ethics grand rounds from the Center of Bioethics. All of these questions really do show how involved and engaged this audience is, and we hope that you'll stay connected with some of our partners here that sponsored this event. Thank you for being here, and be sure you consider attendance at one of our upcoming webinars. In March, we'll be talking about the links between human, animal health, and the environment. And we also want to be sure that there is a document in the link around all of the presentation details. We've been adding some links during your talk, Dr. Hardiman, just to keep it updated. And again, thank you so much for your time today and for your wise and encouraging words.
Thank you.